Hello, everyone. My name is Alyssa Lambrecht, and I am a third-year medical student at Ohio University Heritage College of Osteopathic Medicine and a Capella Fellow for Doctors for America this year. I'm joined today by two individuals who are also passionate about providing the best possible care for patients with substance use disorders. And today we're going to talk about the prevalence of addiction, how providers can work to break down their own biases to help provide better care for these patients, and how to phrase discussions when talking about patients with use disorders to help limit stigma and create a more positive healthcare experience. First, I'd like to introduce Dr. Berkeley Franz, a medical sociologist and health service researcher whose research and teaching focuses on health disparities, population health, and substance use. She has a PhD in sociology from the University of Miami and a master's in religious studies from the University of Chicago. Dr. Franz is an associate professor of community-based health at the Ohio University Heritage College of Osteopathic Medicine in Athens, Ohio, and an Osteopathic Heritage Foundation endowed faculty fellow in population health science. Secondly, we have Dr. Christopher Meyer, a board-certified gastroenterologist and addiction medicine specialist. He completed an internal medicine residency at Flint Osteopathic Hospital and a fellowship in gastroenterology at Yale New Haven Hospital. In 2018, he completed a second fellowship in addiction medicine at the University of Florida College of Medicine, and he is a provider for Ohio Health of Glennis Hospital in Athens, Ohio, and treats patients with substance use disorders on a daily basis. So for today, we're going to start off with a brief presentation, and then we're going to move on to the discussion portion of our conversation. So I'm going to go ahead and share my screen and hand it over to Dr. Meyer.
So these are two definitions. One is from the American Society of Addiction Medicine, the other from the American Psychiatric Association. They're probably the two most commonly used definitions in the field. The schematic on the right really kind of boils it down to language that everybody can understand. Substance use disorders are primarily characterized by compulsive use, by cravings for a substance, continued use despite consequences, and loss of control. Beyond that, we utilize DSM-5 criteria, which are 11 distinct criteria, but they're the same for every substance use disorder, and they have nothing to do with the volume or amount of a substance used or the frequency, but instead have everything to do with the consequences. And stigma is a big deal in this field. Dr. Franz is an expert on stigma as well, probably more so than me. But it impacts every aspect of this particular problem, that being substance use disorders. And ways that we can diminish the impact of stigma in the field and in the profession and healthcare institutions and with patients is to promote this notion that addiction is a disease rather than a moral failing or a constitutional weakness or a personal choice. We know that the disease has a strong genetic predisposition that is felt to account for about 50% of the diathesis or the likelihood that one will develop an addiction. And then the rest of it plays out with environmental influences, adverse childhood experiences, other sorts of trauma that an individual might experience. It's helpful if we stop talking about drunks and alcoholics and addicts and junkies and start talking about individuals. So I work with people who have different substance use disorders. a person with an alcohol use disorder rather than an alcoholic, which is something that folks don't grow up hoping to be. And we talk about persons with opioid use disorders rather than addicts. Avoiding assumptions based on stereotypes is helpful. And in healthcare, particularly in the emergency room and in the hospitals, on the floors, in the back rooms of clinics, there's a propensity to make jokes. Doesn't just happen with people with substance use disorders, but they are particularly susceptible, and it helps to avoid that. So these are numbers, and you can read them. The reality is that the numbers, as stark and as dramatic as they are, probably are misleading. These numbers probably are an underestimate of the actual magnitude of the problem of substance use disorders in this country or virtually any country. And that has to do with underreporting. And the underreporting has to do with failures to screen patients. And because the screening isn't effective, the numbers are underestimated. And these numbers speak for themselves and break down alcohol versus other substance use disorders. Far and away, the single most common substance use disorder is tobacco, followed by alcohol, followed by opioids. The number of people who are struggling with stimulant use disorders, particularly in this era of methamphetamine, are unreliable, again, due to underreporting. We really don't know how big that pool of patients is. More numbers, and they speak for themselves. I don't have much to add to that slide.
So in collaboration with colleagues in psychology and medicine, we've done a lot of research just measuring how common stigma is towards patients with substance use disorders. And most of our research actually has focused on opioid use disorder and kind of individual attitudes among healthcare providers and how they feel about spending time with this patient population and providing their medical care. And so what we found is that bias, which is really just a measure of stigma on the individual level, so that's any individual provider and the potential negative stereotypes that they hold towards patients who meet classification of having an opioid use disorder, is just really common. We've done a couple studies nationally and also some studies looking specifically in Ohio where we're located. And what we found is that negative attitudes are just incredibly common. Most physicians or other healthcare providers would endorse at least one negative attitude towards patients with OUD. And here's a couple of different examples of, and this is measuring really explicit attitudes. So asking people, how much time do you want to spend with these patients? How much do you like, working with them? Things like that. It's not measuring, implicit attitudes, which are also important predictors of behavior as well. But here's a few examples of just kind of explicit bias. We also find a lot of downplaying bias and people who've observed bias, but don't necessarily think that they themselves are ever holding some of those negative attitudes as well. And so kind of recognizing bias in their training or in other healthcare providers. And a lot of rationalizing bias happens as well. And just saying, well, I've experienced a lot of negative behavior in this patient population. And so it kind of justifies differential treatment or worse treatment in some way. And then we also have found that a lot of healthcare providers really regret, having negative attitudes towards patients with OUD or with other forms of SUD, but also don't feel like they're equipped to really kind of change their behavior or change their ability to work with this patient population. And so the last quote talks a lot about just the, how minimal training is in healthcare professions and how that really kind of limits the ability to get kind of comfortable with this patient population. And it kind of leads to continued negative stereotypes. Next slide. So we've done a lot of studies predicting different outcomes. So not just, bias or holding negative attitudes towards patients with OUD. We've also looked at how willing healthcare providers are to take these patients on to their existing panel. And so this is a different study where we looked at different predictors of what makes a healthcare provider willing to work with this patient population. I think it's an important outcome since there are, depending on where you live in the country, there can be pretty significant barriers just to accessing a provider that provides OUD treatment, and especially evidence-based OUD treatment. And I'll talk about this on the next slide, but buprenorphine prescribers are particularly hard to find, especially in rural areas of the United States. And so we're very interested in this question of how does bias then, shape willingness to work with this patient population and maybe exacerbate inability to access care in particular regions. And so we found some interesting predictors that we think are pretty fascinating, and they're also novel in the literature. And one of these is that providers who feel like they themselves are invulnerable to opioid misuse, since they which basically means that they could take opioids for as long as they wanted and not develop an opioid use disorder. Physicians that endorsed that kind of feeling of invulnerability were much less likely to want to work with patients with opioid use disorder. So it just seems like a lack of empathy, maybe one of the drivers here. We also found that perceptions of controllability were really important. And Dr. Meyer mentioned this idea that people still kind of reject this kind of medical model of addiction and believe that it's just a series of poor choices strung together. But providers who endorse that idea are also much less likely to want to take these patients on and work with them. We also found that there are differences in terms of training, and to some extent, internal medicine, family medicine, and emergency medicine physicians are actually more willing than people in specialties to work with patients with OUD. But we find a particularly strong effect for those who have addiction medicine fellowship training in terms of lower kind of bias scores, but in particular willingness to work with this patient population, which is intuitive, but also good to know that additional training in this area does seem to really decrease bias and increases willingness. Next slide. So I mentioned earlier that we're very interested in prescribing behaviors of buprenorphine and other evidence-based treatments for OUD. And what we think is really important is that, for a lot of substance use disorders, there aren't that many treatments available that are that have as strong of evidence as buprenorphine does. And so we all are very familiar with, the rising rates of opioid-related mortality and morbidity in the last couple of decades in the United States. But what I don't think is talked about enough is that we actually have really good treatments available for opioid use disorder in particular. And there's just kind of vastly underutilized. And so that's where we're very interested in understanding how bias contributes to healthcare provider willingness to use these medications. And this is coming from a study that I'm working on right now, and it looks at misinformation related to buprenorphine. And so I think this is another manifestation of stigma, is that sometimes the medications themselves become stigmatized, or the treatments for substance use disorder become stigmatized, and as a result are underutilized. And so I think we've all become kind of familiar with this concept of misinformation in the era of COVID-19 and different myths that were shared about different treatments or vaccination for COVID-19. Misinformation is something that happens kind of constantly in public health, and just kind of sharing of bad information, not necessarily with an intention to mislead people, but it has that effect. And so this looks at how often misinformation related to buprenorphine is endorsed among a sample of physicians, nurse practitioners, and PAs who are all eligible to prescribe buprenorphine. And we find that misinformation is pretty common. At least half of providers endorse at least one piece of misinformation. You can see we measured 5 different pieces of misinformation here. And the most commonly endorsed one is that buprenorphine just substitutes one drug for another. It doesn't actually treat the underlying opioid use disorder. But also there's just other misinformation that buprenorphine is just not effective at preventing overdose deaths, or that it encourages patients to just stay on opioids long term. And so we think this is also really important, that not only patients are stigmatized, but that the treatments for OUD also become stigmatized as well. Next slide. I think I was just going to wrap up and just say is that I think moving forward, what we found from this buprenorphine study is that the single greatest predictor of willingness to work with patients with OUD and also kind of willingness to accept evidence-based treatments for OUD is positive contact. And what that means is just having spent time with a patient with OUD in the past and having that interaction having gone well. And that it didn't create frustration or stress for you, but that you actually saw that as kind of a meaningful or rewarding interaction. And so we're trying to think about ways to build interventions based on these data. And that we think that this really comes probably from just a very small amount of training that students get when they're going through health professions education, that more contact with patients with OUD or substance use disorders would also, increase willingness and decrease kind of the stigma that exists. And so I think there's a lot of opportunities for practical intervention here in terms of increasing availability of evidence-based services.
Okay. Thank you both for presenting that information. I feel like that provides a pretty well-rounded look at just how much bias that there is out in medicine, and something that I feel like I noticed, which is why it kind of prompted the discussion I wanted to have with different providers. So my first question is, have you found, like either through research or talking to colleagues, that some of this bias seems to come from before medicine, or is medical training and like putting on some of this bias on the medical providers, or it's the whole spectrum?
And so I guess the answer is all of that. I think that before healthcare workers enter their field, be it as physicians or nurses or physical therapists or social workers, whatever, I think they probably bring to the field certain biases that are predicated on their life experiences. Once one is in the field, negative experiences with people who struggle with substance use disorders, particularly in the emergency rooms and on hospital floors, may compound that bias. When you think about stigma and who is subject to it in any country, and again, Berkeley probably knows more about this, but when you think about stigma, who are among the most stigmatized individuals? People in the carceral system who are imprisoned for this, that, or the other. Sexual offenders may be the most single group. Substance use, mental health, people with mental health disorders, hence the reference to retards when you're growing up and things of that nature, and substance use disorders. I mean, who else after that? Well, and ethnic, obviously, ethnic background is subject to stigmatizing. So yeah, I mean, it's ubiquitous in society, and we're likely generations away from dealing with it. Berkeley's last slide, the issue of predictors of who is more amenable, I guess, to working with these patients. I think probably people who have a family history of substance use disorders, people whose mom, dad, brother, sister, children struggle with substance use disorders, those who have had good friends. I think those would probably be pretty strong predictors of someone who might be more helpful in dealing with this.
Yeah, I agree with all of that. I think and I hope my research I didn't mean to imply that physicians or other healthcare professionals were unique in having, negative attitudes towards patients with substance use disorders. I totally agree with you, Dr. Meyer. I mean, these attitudes are just really common in society. I think we've all internalized them in ways that we may not even, recognize. But there's lots of evidence out there that, you know, people with mental illness or with substance use disorders are, like you're saying, among the most kind of discredited or undervalued members of society. And you can still ask people today, and they do in public polling and national surveys, like, do you feel like these people are violent, or would you want to sit next to them on a bus, or would you want to have them as your neighbor, or have your child date them? And universally, these things are people are the most kind of disliked, or at least trusted people in society. And so I think that healthcare professionals are just people like everybody else, and that these values, you know, can we kind of pick them up along the way in life. I will say, though, I think there is something interesting about healthcare training, and I'm saying this as somebody who's never gone through healthcare or health professional training itself. But I think having had a negative or positive experience does matter, and it could kind of exacerbate stigma, like you were saying, Dr. Meyer. If you had a bad experience with a patient at one point, our research has shown that if you have a negative experience, what we call negative contact, that is really important. Or if you've experienced kind of stress working with the patient with a substance use disorder, that can be really important, especially if you don't have any other positive experiences to sort of balance that out or buffer that. So say you have very minimal contact with this patient population, and the one time you meet them, it goes, horribly. Of course, that's going to be, a lingering effect in terms of how you evaluate patients with this diagnosis. So I think that's an important point that we have to also just do better. I think there should just be more contact and more training, and that I think the net effect will be something much more positive in terms of comfort and willingness.
Dr. Meyer, can you talk a little bit about your decision to go back to do an addiction medicine specialist fellowship in that field, and just a little bit more about why you felt like there was a need for more to do that extra training after that much time?
I don't feel as though I struggle with a lot of bias in this field and related to people with substance use disorders. And because I'm a relatively open book in this area, I myself struggled with substance use disorders for 30 years. I was an impaired physician. I did get into treatment. I did, I've got 25 years in recovery. So I was a highly functioning person with a substance use disorder, but still struggled. And at a point in time, I decided I had done enough gastroenterology and enough endoscopy and enough scopes, but still wanted to make a contribution. And by that time, had many, many years under my belt of recovery and working in the recovery community in Athens, and thought that it might be interesting to pair all of that with formal training. And so I decided to go back and do a fellowship, and for a short period of time, a couple of years, I was the oldest fellow in the ACGME, a dubious honor. But I've been practicing now for the last 5 years, and I'm glad I did. And comparing my two practices, I don't make a difference with every patient, but I do feel like I make a difference every day. And I didn't always feel that way with gastroenterology. And I guess I would finish saying by in my GI field, I would take care of people with serious problems, pancreatitis, ulcerative colitis, so on and so forth. But the person who is struggling with heroin or alcohol brings into the exam room a level of desperation that I only see referable to those who are struggling with addiction.
Yeah, thank you for sharing that. I think that kind of plays in a little bit to what Dr. Franz was saying about how a lot of physicians, one of their negative things was that they thought they were above addiction, or I feel like talking to other peers, it's like we talk as if this couldn't happen to us, and this is something that our patients are dealing with and not one of our peers or one of our colleagues. And so I feel like knowing that there's support out there and other physicians who are struggling with some of these same thoughts. I think that's important for people to remember as well. Like you mentioned, joking behind closed doors, this isn't a problem that only affects our patients. Someone in that room might be having, similar problems and struggles. So just keeping that in mind. So thank you for sharing that. And Dr. Franz, do you have any tips for physicians who are wanting to look a little bit more into their biases, and what advice can you think of based on your research of what you could tell them on how to um, not overcome them, but notice them, recognize them, and work on becoming a better provider with more compassionate care?
So I have three recommendations, only one of which is based on my own research. The others are based on literature. The first one is actually, there's really compelling evidence that just talking about bias at least once in medical education translates to lower kind of negative attitudes and behaviors later in practice. So this is especially for implicit bias, because those are biases that we just don't know we have. And so that's really powerful to me, that just learning that you have the potential for having bias, I think, is really important. And it seems to translate to kind of just more reflection and kind of interest in how it might be shaping your behaviors later on. So that's the first recommendation I would have. The second one, there's some literature suggesting that there's some kind of cognitive trick you can do when you go in to see patients, and that's just to remind yourself that this patient's an individual and you don't know anything about them. They call it individualizing, and it's just, it reminds you to ask questions and be curious instead of assuming that, oh, I've met somebody like this before, I can maybe assume some things about them. I think that's how stereotypes sort of work. You can kind of use these mental shortcuts to save yourself time. We all do it. We have to do it to survive as humans. But when you're meeting somebody new, it can really, lead to harm if you don't take the time to, ask them about themselves. The third recommendation is just for, improving education, so improving knowledge. And so some of that may happen formally through educational, systems that you're a part of, but some of that might have to be through your own efforts to learn more about this. And, at medical school and medical training requires learning just obviously a vast amount of information in a small amount of time. There's not always time for everything. I get that, but this is so important. And so I really encourage people to take the time to learn more, especially about the treatments that are available and what we know in terms of treating these disorders.
Dr. Meyer, anything to add about that from your experiences?
Well, I mean, yeah, I think, unfortunately, I mean, it's going to take some sort of sea change to, I mean, well, first of all, I agree with Berkeley that what's needed in the healthcare field is education, and that's probably what's needed everywhere as well. Just accepting the disease model. I mean, people who struggle with addiction that I encounter, many of them don't accept that they have a disease. They recoil from the notion that this was a disease. It was a choice. It was a weakness that I had. So it's going to take a sea change to get the education that's needed in medicine. Because, when you talk to medical educators, the first thing out of those mouths is that the curriculum is so crowded, we barely have any room or any time to add in anything else. And I get that, like Berkeley gets that, but the burden to society of addiction in this nation is greater than the financial burden on an annual basis of cancer, coronary artery disease, COPD, and diabetes combined. Every year, the burden of addiction exceeds those combined financial burdens. So to me, it's more an issue of priority and a reordering of the priorities amongst those who are responsible for training, not just physicians, but training healthcare providers of every ilk, be it a nurse, a doctor, a physical therapist, a lab tech, or whatever.
Thank you. So besides just the numbers and like the prevalence of substance use disorder, that should make it like every specialty's goal to help with patient treatment. But I feel like there's still that standard of, well, this isn't my area. I'm going to send them out to an addiction medicine specialist or to their family doctor. Do you have any advice for just why every specialty needs to care about this, and any stories or situations where you felt like it needed to be more of a team effort than what it was in that patient's case?
Only that in every specialty, the nature of the current situation is that we underscreen and we underreport. So, 20% of people who are admitted to my hospital every day have a substance use disorder. 15 to 16% of your classmates in your medical school class have a substance use disorder. Those go undetected. They don't get screened for. We overlook. And to me, that should be impetus to make those changes, but I'm not terribly optimistic that they are on the horizon.
Yeah, I think that's an excellent point. I would also just add that addiction medicine providers aren't available everywhere either. And so it's not a practical, process to just say, I'm going to refer this to somebody with expertise in this area. So we know that especially in rural areas, addiction medicine providers are really few and far between. And so I think we need other specialties to get training in this. And some of the ones that I think hold a lot of potential are really the kind of like broader primary care spectrum. So people who are family medicine providers or internal medicine providers, but also be kind providers and pediatricians. I mean, there's a lot of people that I think would really be kind of a broader frontline, emergency medicine, of course, and infectious disease, given the complications of injection drug use in particular. And so I think there is a much broader need in that it can't fall on just one specialty to do all the screening or all the treatment for SUD.
Yeah, the providers is an issue. When I applied for addiction medicine fellowships in 2016, there were 17 fellowships at the time. You contrast that number to the 146 sports medicine fellowships that existed at that time. Priorities.
Yeah, thank you. Are there any other last minute pieces of advice or things that you've learned throughout your research or your experience working with patients with substance use disorder that you think it's important for medical students, residents, physicians to know, regardless of what field they're practicing in?
I think we talked about it. Stigma, compassion, open-mindedness.
Yeah, I agree. I would just add that, substance use disorders are treatable. We have evidence-based treatments for them. And I think sometimes there's a lot of kind of pessimism about, why even try? And I think that knowing the treatments that exist maybe will give people more confidence and willingness to work with this patient population.
All right. Well, thank you both for spending the time chatting about this today. I think it is something that's really important that I've seen in the first few months of even my clinical rotation, some of the bias in practice. And so I think, just having that short of a time and already seeing some of these negative situations, I'm hoping people will be willing to take the time to learn a little bit more about how to recognize your own biases, because they are there and everyone has them. And hopefully this discussion just will bring those up and people can see that a little bit more and work on becoming a more compassionate provider. Unless there's any other last minute pieces of advice, then we'll head off for today.
Okay. Well, thanks for having me. Us.
Thanks.